Prenatal diagnosis of fetal or congenital abnormalities is a hot topic in obstetric practice today. It is very important as a first contact doctor for you to understand the basics of prenatal diagnosis and how it is being practiced in Sri Lanka. At the same time, you need to have some idea about the new developments in the field. So for ease of uploading and consumption, I have divided this lecture into 3 parts. So in the first part, we will discuss what is prenatal diagnosis, what is a screening test, and what is a diagnostic test, and then what are the other prenatal screening tests which we do during antenatal period, and then common prenatal screening tests and diagnostic tests and diagnostic methods which we use, and then a little bit of a primer which will recall your genetics knowledge and the genetic basis of fetal abnormalities and how we screen for these abnormalities in pregnancy. So that will be the first part of the 3-part lecture series. In the next part, we will discuss deeply into each method of screening as well as diagnosis. We are going to discuss prenatal diagnosis and congenital anomalies, and for ease of uploading and consumption, I have divided this lecture into 3 parts. In the first part, we will discuss what is prenatal diagnosis, and we will discuss a little bit about what a screening test and what a diagnostic test is, and what are the common screening tests which are performed outside of the context of diagnosing fetal anomalies, which we do in antenatal period. And then we will look into the common screening and diagnostic methods which are available briefly before going into details, and then we will recall the genetic basis of fetal abnormalities which we learnt in our anatomy days in genetics lectures, and then we will identify the common screening methods or the diagnostic methods which we have for identifying the fetal abnormalities. That will be the first lecture, and in the second and subsequent lectures we will go into details about each method and some of the common utilities. So what is prenatal diagnosis? The key word here is prenatal. So anything which is diagnosed about the fetus while the woman is pregnant falls under this category of prenatal diagnosis. So in other words, fetal growth restriction, macrosomia and other conditions which we diagnose during pregnancy are also part of prenatal diagnosis. That is the broadest definition of prenatal diagnosis. But in modern practice, this is not what we are really meant by prenatal diagnosis. Here what we are concentrating mainly is the abnormalities, genetic or structural abnormalities or the congenital abnormalities or chromosomal abnormalities, which we can pick up early in pregnancy sometimes to identify and then if possible to treat, or sometimes to give the parents the choice of continuing with the pregnancy or going for termination, or for them to be ready with whatever they can do to look after the baby after the delivery. So those are the common scenarios of prenatal diagnosis and the practice of prenatal diagnosis which we have today. Before going to discuss prenatal diagnosis or any test, which we need to recall our knowledge about what a screening test and what a diagnostic test is. There are two types of tests which we use in the context, in any context. The screening test, if you can recall your community medicine lectures, are the tests which we done on generally healthy population to identify any disease condition early. Most of the time these patients are asymptomatic or in very early stages of the disease. Classic example of a good screening test is our pap smear. We do pap smears on people who are completely asymptomatic. They may not have any symptoms, but they might have early changes of cervical cancer on the cervical epithelium when we do pap smears. So in prenatal diagnosis also, what we do is completely normal looking pregnancy in early stages. We do various tests. We do mother's blood tests, we do ultrasound scans, we check various DNA or other particles which are released from the baby on the mother's blood, and then see whether we can come to some conclusions about the baby's condition. The diagnostic test, on the other hand, is to confirm the diagnosis. Most of the time in pregnancy, this involves taking a sample from the fetus. Now in the pap smear example, the diagnostic test of a suspected abnormal pap smear report is cervical biopsy, most of the time colposcopic guided biopsy or a cone biopsy or loop biopsy in the theatre. After that we will have the histological diagnosis. In the same way, in prenatal diagnosis, when the prenatal screening blood tests or other tests tells us that the baby is having a high risk of a condition, we go for diagnostic test. In this context, in the prenatal diagnostic context, the commonest way of obtaining fetal tissue is amniocentesis and chorionic villus sampling. They will help us to obtain fetal tissue and come to conclusions about the baby. Occasionally when we are worried about fetal infections, we might take only amniotic fluid and culture them for various organisms and do various molecular testings to identify them. But most of the time when we go for fetal abnormalities like say Down syndrome, we go for chorionic villus sampling or amniocentesis to diagnose. As we learnt in our community medicine lecture, any screening test needs to ideally fulfill certain criteria, which you may have learnt and remembered. There are 10 of them. I'm not going into detail but out of them, the commonest thing is that the condition has to be important. There should be some sort of a treatment or management pathway for the diagnosed condition. There should be easily available facilities for diagnosis and the treatment. Some of the prenatal diagnostic tests may not fall into this category because they are expensive. Most of the people may not have enough means to access them, but still it is available. There may have to be an early symptomatic or latent phase in most of the condition. In prenatal diagnostic conditions like Down syndrome, it is so. And there should be easily applicable test, and the test should be acceptable to the population. With regard to prenatal diagnosis, it is common, and in other countries it's widespread and widely practiced. Unfortunately, in our condition it's not so. And we should have some idea about the natural history of the condition, how it is developing and what will happen in the future if we don't treat them. And there should be a agreed policy of management of these patients, and the cost should be manageable, as I mentioned earlier. And then there should be a way of continuity of this program of screening. So if it is being offered by the government, there has to be funding, staff and other resources allocated for screening. This is the same criteria, have divided them into 3 groups: features about the disease, features about the test, features about the population which are being screened, but the same things. So what are the screening tests which we have in antenatal period? Everything which we do in antenatal period is actually a kind of screening, because we don't really see the patient, who is the baby inside the mother's womb. But in modern practice, blood serum, maternal serum blood tests, ultrasound scanning, and cell-free fetal DNA tests are the commonest medical technologies which are available for diagnosing the fetal conditions. But growth measurements, ultrasound measurements are also part of prenatal diagnosis, but we don't really offer them to diagnose abnormalities as such. Because of that reason, we will not be talking about them, but you need to keep in mind that everything which we do in antenatal period is kind of a large multi-stage, done in several stages, in each which we screen mother for hypertension, diabetes, growth abnormalities and other diseases. So we will be doing this as a large scale screening program. Coming back to prenatal diagnostics testing, we have primarily we are aiming our diagnostic and screening tests for identifying structural congenital abnormalities. Out of the genetic abnormalities, the number of chromosomes or their changes, abnormalities of chromosomes, deletions, translocations, and genetic abnormalities like thalassemia and Rh diseases may be picked up. Please go back to your genetics notes. I will try to give you a primer here. We know that our body functions are all planned and controlled by our genes, genetic materials, and there are long strands of DNA formed into 46 chromosomes, and which are paired into 22 autosomes and 1 pair of sex chromosomes, and we get one each chromosome from each parent. So that is how we form 46 chromosomes. During cell division and during the life of the cells, these chromosomal material can get damaged, get changed, or they may separate out into different parts. Natural repair mechanisms are there which will repair them, but sometimes they don't do the job properly, and there are various errors in the repair process. Because of those things, we will end up with structural abnormalities of the chromosomes, numerical abnormalities of the chromosomes which are called aneuploidies, or sometimes large portions of chromosomes can get missing or can get duplicated. So they are again structural abnormalities of chromosomes, and then sometimes small parts of the gene, very small fragments of DNA can get missing or can get deleted. So we get single gene or sometimes few isolated genetic abnormalities. So you can have abnormalities of single genes, multiple genes, portions of chromosomes and number of chromosomes. So there are possibilities of several levels of errors in our inherited material or hereditary material. So if we are to find for causes or abnormalities, we need to find all of these. There are methods which are available in the modern day genetics to identify almost all the abnormalities, but because of the cost and practicalities, they are not being done. So most of the time we focus on some of the commonest abnormalities which we have. We'll come to that later. With regard to chromosomal abnormality, as I said, there are changes in the number as well as the structure of chromosomes. The numerical abnormalities are called ploidy abnormalities. During the cell division, if some chromosomes get loaded into one cell rather than the other one, then we will end up with aneuploidy abnormalities. Commonest one which almost everyone knows is monosomies and trisomies. Down syndrome is trisomy 21, Edwards is trisomy 18, Patel is trisomy 13. Occasionally we will have tetrasomies and monosomies as well. Then we have duplication of the whole chromosomal complement, the whole set of chromosomes increasing. Triploidy is common and is commonly seen in a gynecological condition in early pregnancy called partial moles. They are a triploid. Most of the early pregnancy miscarriages are having polyploidy or triploidy or tetraploidy abnormalities. So they are the numerical abnormalities. And even trisomies, most of them actually end up as miscarriages prior to third trimester. There are structural abnormalities of chromosomes, deletions, inversions, isochromosome, ring chromosomes. I'm not going into detail, but please visit your genetic lectures to refresh your knowledge on these areas. And then there are abnormalities, structural abnormalities involving more than one chromosomes, reciprocal translocations, 15 and 21 again, which will give rise to kind of Down syndrome, which is called translocation Downs, and in this condition it can get inherited. So it's of different nature than aneuploidy. Aneuploidy related trisomies are age related. Translocation related trisomies are not age related. It can happen to anybody, and you need to differentiate these two. So if you see a Downs baby in your pediatric ward on your natal unit, you need to make sure that the baby's karyotyping is done and then identify whether this is a translocation. If it is a translocation, you need to counsel and send the patient back to the obstetricians for pre-pregnancy counseling, because they need to be given the information about the risk of recurrences. If it is aneuploidy related, if the mother is old, it will happen, but if it is not, she only has the age related risk. Occasionally we may have abnormalities due to mosaicism, or some people will have different cell lines occurring at the same time. So there may be more than one cell line in the body, and they will have various chromosomal abnormalities. So this is a trisomy 21, this is a trisomy 18. You can see 18 chromosomes, 21 chromosome in each of these in arrow marks. This is the tetraploidy and triploidy. You can see 69 total amount. This is 92, 4 times the 23. These are the common structural abnormalities due to deletions, due to duplication. You can see parts of the chromosome has extended, then inversion, substitution one part from the other, and translocation. This is a 4, 20 translocation of a chromosome. And then, apart from these genetic related abnormalities, some structural abnormalities come during the development. We know that genetics is not the whole story of a baby's development. Various cells will have to grow, undergo translocation, undergo expansion, and then sometimes they migrate. If those things don't happen properly, there will be a discordant growth of an organ. Those parts of a large organ may not develop in coordination. In that case again, the baby will end up with abnormality. Most of these structural abnormalities are called congenital abnormalities. They happen during the embryonic life. Some of them may have genetic basis, which we may not have discovered yet, but most of them they are due to malfunctioning of the cellular and embryonic processes or early in embryonic or in early fetal life. So they have discordant growth or discordant abnormalities in the structures of the organs. Actually speaking, structural abnormalities are the commonest compared to chromosomal abnormalities. Structural developmental abnormalities are commonly we see them in cardiac system, because the heart is one of the most complex organs in the fetal body. Then comes the genitourinary system. You can see out of 1,000 births, 10 can inherit this. Then gastrointestinal, neurological, craniofacial, all these things, if you go back to your embryology days, you recall all these structures, the face, heart, genitourinary system needs multiple parts and tissues playing their role in a coordinated fashion. If they don't happen, you will end up with the abnormality. Out of the chromosomal abnormalities, if you take 1,000 births, all chromosomal abnormalities will come to about 9.1. You can see about 10% cardiac, 10% genitourinary, all chromosomal will be close to 9% or less than 10%. The trisomy 21 or the Down syndrome account for the largest portion of chromosomal abnormality. Then we have monosomies, trisomy 18 and trisomy 13 in other in the next levels. There are some single genetic gene abnormalities which may be of importance. Achondroplasia, Duchenne muscular dystrophy, thalassemia are common single gene disorders which are of clinical significance. We can even diagnose genes which are responsible for Rh status, and they may also be of help in managing the babies. So these tests, all these tests will need some sort of a invasive diagnostic test rather than screening test like amniocentesis, chorionucleus biopsy, or cell-free fetal DNA testing. And how do we screen for these abnormalities? We screen them primarily the structural abnormalities are screened by ultrasound. And sometimes we combine that with various serum tests. Say out of the structural abnormalities, the first thing which we notice in early pregnancy is the spinal cord or the spina bifida. Most of the time the diagnosis is nowadays done with ultrasound, but before that we used to do alpha fetoprotein levels, because open spina bifida will increase the alpha fetoprotein level in the maternal the baby's amniotic fluid. So one of the reasons for amniocentesis was to diagnose neural tube defects, but it is no longer the case because ultrasound is so sensitive. We don't do amniocentesis to diagnose neural tube defects anymore. Other genetic abnormalities like thalassemia or Down syndrome are usually diagnosed by maternal history or family history. Say Duchenne muscular dystrophy, we go by the family history, and then we sometimes offer the mother certain blood tests and other molecular genetic testing. The number of chromosomes or the aneuploidy abnormalities are usually done by the history or the risk factor based screening, maternal serum screening, triple test, quadruple test, combined test, integrated test, which we will come into discussion later in the next lecture, and recently developed cell-free fetal DNA from the maternal serum. I have given you some additional reading material. Please go to the model and look for the final year topics. In the final year topics, there's a topic called prenatal diagnosis. I have uploaded 2 articles, one on the screening and one on the diagnosis of fetal genetic abnormalities. Please read them. They will give you, they may be difficult for you to understand in the first go, but take them down separately and leisurely, and they will give you a better idea about the topics which we will be discussing in the next lecture. Okay, thank you. We'll meet in the next lecture in few minutes.